Welcome to everyone from around the world. It's really wonderful to see so many people joining. I'm Ali Ferguson. I'm a physiotherapist at Queensland Children's Hospital in Australia, and I'm the current chair of the WFPICCS Allied Health Committee. And together with co-chair Kathleen Parkes, I'd really like to welcome you all here tonight. It is tonight in Australia, but maybe morning wherever you are. We've got a wonderful panel of presenters today that we're going to hear on the topic, could it be sepsis? So without further delay, I'd like to welcome our presenters, Michelle Cree, Lisa Lee, Professor Loren Schlappbach, and Sophie Weeks. So Michelle is the pharmacist lead for critical care at Queensland Children's Hospital and PhD student at the University of Queensland Centre for Clinical Research. Lisa Lee is a clinical pharmacist at the Boston Children's Hospital, who is working in the Medical Surgical Intensive Care Unit. Professor Loren Schlappbach is the head of Pediatric and Neonatal Intensive Care Unit at the University Children's Hospital. And Sophie Weeks is a social worker acute clinical lead at Queensland Children's Hospital in Australia. And I'd really like to thank this wonderful multidisciplinary panel for putting this together. Thanks, Michelle, for coordinating everyone, and thank you so much, everyone, for your input. If I can ask everyone to have their microphones on mute, please. And at the end of the webinar and presentations, we will have a Q&A session where we'll open the floor. So welcome and enjoy the webinar.
Thanks, Ali, for that introduction. And again, good morning, evening, and good night, wherever you are in the world. This is the Allied Health presentation facilitated by the Allied Health Pharmacist Representative in WFPICCS. Could this be sepsis? Firstly, I would like to acknowledge the traditional owners of the land where we gather here today. And for me, that's the Turrbal people, and pay my respects to the elders past, present, and emerging. So this talk will talk about an overview about what is sepsis and the difficulty in diagnosing. And then where Professor Loren Schlappbach will inform us about the burden of disease, and we'll look at what's new and how we can actually help in diagnosing sepsis. And then we'll look at what we have in Australia and Queensland to help us look at diagnosing sepsis, and as well around the world. Then we'll have Sophie, Weeks who'll tell us about the actual family and what their perspective and tools are available for them. And then finally, we will look at what antimicrobial treatments are available around the globe, focusing on Australia, United States, India, and Africa, where Lisa and myself will summarise treatments and antibiograms, looking at the resistance, concluding with our take-home message. So if we look at what is sepsis, we have here a child who's presenting with a runny nose. Could this be sepsis? Well, we have a picture here of a child that is clearly septic. We know there this child has a renal replacement therapy, so they have one organ failing, as well as being ventilated. So we know that they've got two organs that needing support. The surviving sepsis guideline defines sepsis as a dysregulated host response to an infection that can either be bacterial, viral, or fungal, resulting in life-threatening organ dysfunction. We know diagnosing sepsis is not easy. There is no right or wrong answer. You will see many kinds of patients like this in your career, and many even in one shift. We can't do septic screens for everyone, but we need to look out for those patients and advocate for them and use our greatest skill, the clinical examination. We need to be like Sherlock Holmes, look for the abnormal and try and find the source of infection, of the fever or infection. Now, I'd like to introduce Professor Loren Schlappbach, who is the head of the Pediatric and Neonatal Intensive Care Unit at the University Children's Hospital Zurich, Switzerland, and lead researcher in pediatric sepsis. He's published over 250 papers in the field. He's the past chair of the Australian New Zealand Intensive Care Society of Pediatric Study Group, and is serving in the steering committee of a number of PICU trials. Loren's research focuses on sepsis and life-threatening inflammation in critically ill children, including aspects as epidemiology, outcome prediction, biomarkers, interventional trials, and genomics in this highly vulnerable patient group. It's interested in improving our understanding of why some children become critically unwell and in developing better approaches to allow early recognition and targeted treatments of sepsis. Loren is an internationally respected and recognized expert in sepsis and other life-threatening infectious and inflammatory condition, and is group head of the Pediatric Surviving Sepsis campaign and co-chair of the International Pediatric Sepsis Definition Task Force and the chair of the NSPICCS section on infection, inflammation, and sepsis. Please welcome Professor Loren Chouplat. A minute. Sorry. Okay, can we see that? No.
Dear colleagues, in the next roughly 5 minutes, I will present some updates on what's new in pediatric sepsis. Obviously, this will be a very, very brief and gross summary actually of what's happened in literature over the last few years. The first point is that we have acquired new insights into the true burden of disease in relation to sepsis overall, but more specifically in relation to pediatric sepsis. The 2017 Global Burden of Disease, published by Christina Rudd and colleagues in The Lancet in 2020, has evidence that roughly 50% of the 50 million sepsis cases worldwide, so about 25 million, occur in neonatal and pediatric age groups globally. And the associated toll on mortality is about 3 million deaths for all pediatric age groups. What the burden of disease study has shown as well is that although the burden is absolutely disproportionate in low and middle income countries, where over 80% of the overall global burden of disease happens, that even in high income countries, sepsis remains amongst the leading causes of mortality and morbidity across many settings. And so this global burden of disease study for the first time provides robust data based on coding systems to characterize actually the true burden of disease around the world. This is a major advantage compared to previous studies, which usually just were limited to a few countries, and most of which actually were biased towards high-income countries. What the global burden of disease study does not show us actually is what the costs are of sepsis and what as well long-term effects may result from sepsis. Estimates in the US by Erin Carlton and colleagues, published in JAMA Pediatrics, report a cost of about $7.3 billion every year in the US alone. The associated cost per episode is estimated around the 70,000. So these estimates are have gone up compared to previous data that were published over 10 years ago. What's shown in these data is as well that in high-income countries, the burden of sepsis on one side affects children with chronic comorbidities and chronic healthcare costs, where sepsis actually increases healthcare costs. And at the same time, there are children that have been previously fully healthy, where sepsis results in new healthcare costs. What several studies have shown, and the largest to date being the LAP study led by Jared Zimmerman and colleagues, is that about a third of sepsis survivors, as well pediatric survivors, experience some type of deterioration in health-related quality of life after the first year of the sepsis. Now, what's interesting to see is that this may affect overall health-related quality of life, such as measured by the PICCS score, or by aspects such as the functional status score. There are some other studies, for example, on patients that had sepsis associated with oncologic disease, which shows that using more granular tests, such as executive function, that actually some long-term effects may go beyond some of the early effects observed. What's interesting to see as well that the impact of sepsis and health-related quality of life changes over time. The strongest impact seems to be observed within the first few months, with some recovery seen in some patients by 6 to 12 months after. At the same time as well, what is obvious again there is that health-related quality of life in sepsis needs to be considered against the baseline health-related quality of life that these patients have, in particular if they had previous chronic conditions. But even under that consideration, it's been shown in recent data from the US that about a fifth of all children with sepsis will develop either a new medical condition, or actually children that have medical conditions develop worse medical conditions. Now, given that the average child with sepsis is just a few years of age, this long-term morbidity has an impact on the child and the society, for decades to come. And this disproportionate impact of pediatric sepsis is something which has not been reflected sufficiently in many global cost models. Now, this was in relation to the burden. Now, what has changed over the last few years? What insights have we gained in relation to management of pediatric sepsis? I think there's been major progress in the deployment and the further refinement of quality improvement initiatives. One of the largest ones is the IPSO collaborative in the US of leading children's hospitals, which has learned actually from previous pediatric septic collaboratives in the US, as well as from the New York sepsis work. In the UK, this is the Sepsis 6, and in Australia, based on work done in New South Wales and then in Queensland, a national sepsis standard has been developed. And I invite you actually to look at the Australian Commission on Safety and Quality in Healthcare, where you can find actually details on the sepsis standard that Australia actually has established. Out of all of these quality improvement initiatives, by far the most published is the IPSO collaborative, which has published a number of reports, including how to operationalize sepsis in the context of quality improvement, which measures actually to consider. And they have reported as well on a number of their findings, actually, which demonstrate the major impact such quality improvement initiatives can have. To date, actually, despite the fact that several quality improvement initiatives are happening as well in low and middle income countries, these have been less reported on, and we really look forward to see analysis actually on the impact of those. However, what remains a fact is that most recommendations that were included in the 2020 Pediatric Surviving Sepsis Guidelines, and these are 77 in total, many of those are not based on pediatric specific high-grade evidence. So at this stage, still the evidence base for the best treatment in children remains very, very limited. It's often based on small studies or inference of adult data, for example. And it is really urgent that we get evidence based on large trials. In this context, it is really encouraging that several large trials on pediatric sepsis are on the way. For example, the PROMPT bolus study led from Children's Hospital of Philadelphia, which investigates the balanced fluid resuscitation versus normal saline. The SHIP study, which investigates the use of hydrocortisone, and the response study from Australia as well. So this is in relation to treatment. In relation to diagnosis, which remains sort of the first key point, actually, when we probably can make a difference to enhance and speed the timely treatment of sepsis. To date, still a lot of work needs to be done. There are more and more papers coming out on novel algorithms or scores or tools actually to recognize sepsis, but many of these actually have not been broadly validated. It's very encouraging to see that AI-assisted approaches may potentially enable early recognition of sepsis, but often these are published within very, very specific settings, and it's not yet clear how these can be optimized and deployed in larger institutions, and as well to what degree they can be generalized as well to less resourced settings. What remains an important controversy is that in the context of screening for sepsis, more and more children may be recognized as potentially heading towards sepsis. And this poses a challenge for the judicious use of antimicrobials. This is one of the areas where maybe most work needs to be done in the next few years to really show that sepsis campaigns which aim to deliver antibiotics in a timely fashion to the right patients actually should go hand in hand with antimicrobial stewardship campaigns rather than being seen as an opposite. Encouraging news in this context from Australia actually indicate that embedding strong antimicrobial stewardship within pediatric sepsis campaigns has the potential actually, to improve the way antibiotics are used. But a lot of work actually, will need to be done. One of the hopes, of course, had been that better biomarkers can essentially address this issue. And to date, I think it's fair to say that biomarkers have not yet solved the issue, although we do hope that new biomarkers, for example, based on gene expression patterns, can be more accurate in defining which patient actually would benefit from antimicrobials. The field of biomarkers, however, has been extremely fascinating in a way that actually the biomarker approaches, in particular transcriptomics, have permitted over the last few years to improve our understanding of the host response to infection. And in this context, with work led from Hector Wong over 10 years ago, and in the last few years as well, a lot of work done in adults, these host response signatures have shown how patients that have similar biological or clinical characteristics often actually may result in similar outcomes, and that if we can target these endotypes, that we may have an opportunity to deliver more personalized interventions. At this stage, however, we're just at the beginning of delivering more personalized medicine to children with sepsis. The most promising field certainly is the field of immune modulation, where a number of trials actually have started. I've mentioned the hydrocortisone trial, but there are as well, trials in the US actually that specifically try to phenotype patients based on their host response for to then be selected for more specific immunomodulative therapies. So I think in the next few years, hopefully we should see a lot more in this space and get better evidence, which then can inform the next iteration of the Surviving Sepsis campaign too.
So thank you, Loren, for that valuable information. We're just going to go to the next part. And I have shared the screen, I assume, so we can all see. We're just going to talk about now the sepsis pathway. As Loren talked about, there are new and the use of algorithms and various options here. So what we do know that there is the sepsis pathway that we use here in Queensland. This looks at recognition of... Okay.
Thank you.
Try again. Apologies about that. So thanks, Loren, for what was new in the algorithms and what's in sepsis. But now we're going to focus on here a sepsis pathway, which Loren mentioned, which we use in Queensland. So this is a recognition pathway. There's a paper documentation here looking at many factors in how we could actually help diagnose sepsis. If sepsis is suspected, we need to really think about immediate action. It's firstly, we just need to look at screening and recognizing it and identifying signs of infection or history of and evidence of fever or hypothermia. Then we need to think at the additional things to look at, which is, does the patient actually look sick? Do they have a lactate that's actually greater than 2 millimoles per litre? Are they tachycardic? What's the parent's concern? What are we actually doing about that action? Is it a representation? Were they only here yesterday or last week or the last few days? Are they immunocompromised and actually receiving chemotherapy? Do they have an altered behaviour? Are they actually not their normal self? What's their conscious state? And have they had a sepsis admission in the last 30 days? We know that does increase that actual risk, as Lorraine mentioned. We know here in Australia, Indigenous children certainly have an increased risk of actual sepsis as well. And especially if you're under 3 months, that also increases that risk. So if sepsis is suspected, immediate access is required. We firstly need to get some blood cultures to confirm the pathogen. Then we need to think about what we're actually going to be the potential source and then target that with our actual antimicrobials. If required, we may need to give some fluid boluses, as Lorraine mentioned, so considered balanced solutions. And you may need to also think about whether we need to have early inotropes if they are peripherally shut down. And then we need to think about that we are addressing this fairly quickly. Now I would like to introduce Sophie Weeks, who will provide us an insight into the family perspective. Sophie is the acute clinical lead at the Pediatric social work team at Queensland Children's Hospital. She has a special interest in acute care and grief, loss and bereavement, and is passionate about patients and families having access to psychosocial support. Her current interests are around exploring the psychosocial needs of children receiving end-of-life care, as well as developing consumer engagement strategies. Welcome, Sophie.
Thanks so much, Michelle. Can you hear me okay?
Yes.
Oh, good. Good evening or good morning, everyone, depending on where you are. And thank you so much for joining us. I'm really grateful for the opportunity to speak about this topic that touches the lives of children and family worldwide, as we've already heard from Lorraine. I also wanted to talk about the pivotal role of social work and family engagement. As we discuss the intricacies of pediatric sepsis, a life-threatening condition that claims countless young lives each year, it's imperative that we recognise the multifaceted nature of this crisis. Beyond the medical complexities of diagnosis and treatment, there lies a critical need for holistic, compassionate care that considers the emotional, social, psychological well-being of both the child and their family. As you know, pediatric sepsis is often characterised by its rapid onset and devastating consequences. The young patients and their families embark on a journey fraught with fear, uncertainty, and despair. Social workers play a pivotal role in addressing the emotional and psychological needs of the families. The trauma of witnessing a child suffer is profound, and parents often show grief, fear, and guilt. Social workers provide a safe space for parents to express their emotions and to offer strategies to cope with the turmoil. We also need to consider the role of each family member in the multidisciplinary team working with these families, as well as the role of parents and carers themselves as key members of this team and as part of the pathway. Research with families affected by sepsis has highlighted the critical importance of looking beyond the traditional acute phase of avoid and treat organ dysfunction and instead recognise the role and value of patient-centred care for sepsis. As we explore the ways to recognise and manage sepsis, it's important to investigate the support structures and processes required by families and review the implications of sepsis recovery for survivors and the healthcare system on an ongoing basis, thereby encompassing holistic patient and family-centred care. Through consultation with parents and carers, we know having a child diagnosed with sepsis is a life-changing event. Parents and carers experience a unique sense of isolation and uncertainty in their child having had and potentially being significantly affected by an unknown or unfamiliar condition. In recognising this impact, we want families who have experienced sepsis to be well supported, to be able to connect with one another with similar experiences, and to have access to useful information and resources. The Queensland Pediatric Sepsis Program, as you can see in the slide, works collaboratively with clinical social workers, other members of the multidisciplinary team in delivering a family support program to all families here in Queensland affected by sepsis. The program elements have been co-designed by consumers and are in part delivered by consumers and offer key supports and resources to all points of the journey, from the acute phase of diagnosis to discharge, longer-term recovery, and into bereavement if the child does not survive. The various aspects of the family support program are multimodal, thereby increasing the opportunities for families to connect and process the information at any time during the acute episode of sepsis or afterwards, from any location within Queensland, or for that matter across Australia and the world, with regards to the website accessible information, which again you can see on your screen. This includes a family support network, a peer mentor program, educational videos and resources, to name a few. Family engagement is a fundamental aspect of paediatric sepsis care on the ward. Social workers promote the active involvement of families in their child's treatment plan, helping them to become partners in the healing process. This collaborative approach fosters a sense of agency and control amidst the chaos, instilling hope and resilience. With a multidisciplinary approach and active involvement of families and consumers, we can ensure comprehensive care that extends beyond the confines of the hospital room. Together, as a united front, we can provide not only medical intervention, but also the compassion and support that families desperately need. Thank you again for including me tonight. Back to you, Michelle.
Thank you, Sophie, for that information about the perspective of whatever family and what we can offer for the family for support. So now we're going to, or maybe not. Yep. Now we're going to look at what treatments are available that we can use. And look, we're now focusing on empirically around the world. So firstly, we're going to focus on Australia and where I live, which is in Queensland, and look at what we actually have around. So we have the Queensland screening tool, which we're using in an IMR, and this has helped and linked in looking at the intelligence of looking at a child early warning tool, looking at a team approach, and the empiric antimicrobials. You can see here that you actually have, once it is suspected, that these things automated and are linked in whether it's urgent or not urgent, and how to actually facilitate that to make it easier for recognition and diagnosis. We look at the antimicrobial treatments we have in Queensland. We have here the our sepsis recommendations, and we look at here the greater than 2 months of age. And essentially, it's the same if you're under 2 months. The only addition is that we add ampicillin, which we use for listeria because they have a higher risk, and we are concerned about that. So we focus up here. The general aspect is using cefotaxime as our predominant antimicrobial. And from that point, in trying to optimize the dosing. Then if we're actually looking at an MRSA susceptibility, we would actually add in lincomycin. And then we're following on, if it's actually a multi-resistant, we'd add the vancomycin. If we do have septic shock, this is where we would actually add in gentamicin here and consider a therapeutic drug monitoring, which we would also do for our vancomycin. Unfortunately, therapeutic drug monitoring is not available for every antimicrobial, but with time and future options, that may be something we can see in the future. If you actually come from Northern Queensland, we know there is a wet season, and that is also typical of our Northern Territory in Australia, where we actually have to consider other pathogens. And this is where we would look at melioidosis, and we would need to consider changing our cefotaxime to meropenem in that part. We also know that if children have actual travel to Asia and that we have a higher resistant patterns there, we need to look at individualising the treatments. And Australia is not a resource poor country, so availability to antimicrobials may vary from other parts in the world, which we'll see very shortly. However, to note, our guidelines do not have evidence in critically ill children and are limited with pharmacokinetic studies in this not being available. So certainly more research is needed. As Lorraine mentioned, we need to look at precision dosing and look at potentially covariance to see what we can do to include and improve pharmacokinetic and pharmacodynamic targets to make sure that we actually get optimal antimicrobials. So if we now look at our antibiograms or resistant patterns, here is a table looking at all Australian hospitals from January to December 2018, and Queensland Children's is included in that, but it is all hospitals. And you can see that looking at susceptibility, we know that if we look at firstly coagulase negative staph, you can see the standard penicillins, flucloxacillin, and a lot of this here has potential resistant isolates, which is concerning, and we need to think about how we actually use these wisely. So now I'd like to hand over to, I'm just going to stop sharing at first. Now I'd like to hand over to Lisa Lee, who is the PICU pharmacist at the Boston Children's Hospital, and she will tell us about United States of America and India. And I'd like to acknowledge Professor Jashri Madhaharan for her content in this actual presentation.
Hello, everyone. Thank you, Michelle, for the introduction. So now I will be talking about Boston Children's Hospital sepsis recognition and management workflow, including some empiric antibiotic recommendations, as well as antibiogram in the United States. So here at Boston Children's Hospital, we have a sepsis working group that continuously reviews and looks at quality improvement in the process of sepsis management. The sepsis working group has put together a sepsis trigger tool that will help the bedside clinician identify sepsis in a patient for early recognition. Once the bedside clinician, usually a nurse, has recognized sepsis in a patient, this tool is also used in our emergency department as well in patients that are coming in from the outside. Once the staff has use the sepsis tool to recognize sepsis, then they will call a huddle at bedside with the primary care team. The primary care team consists of the medical providers as well as nursing, and they will decide if treatment is needed at a time. Once treatment is deemed needed, they will use a sepsis order set to order the diagnostics and treatment. In this order set, treatments include fluids, inotropes, as well as empiric antimicrobials. We ask that the providers use a sepsis order set to order antimicrobial because we want the pharmacy to be part of the team to facilitate rapid administration of antibiotics to these types of patients. So once the medication is ordered in the sepsis order set, the antimicrobial is alerted to the pharmacy staff that this medication is for the indication of sepsis. So at that point, we will prepare and deliver the medication at appropriate time so that nursing can administer the medication or antimicrobial within 60 minutes of sepsis identification. In terms of our empiric sepsis antibiotic recommendation, this is a very general overview of our recommendations for antibiotics. It is set up in 4 different parts. The first part is neonatal sepsis antibiotic recommendations. There are 3 regimens listed here based on their age as well as comorbidities and indication. For patients that are in hospital for less than 2 days, we define that as community-acquired sepsis, and the empiric treatment option is ceftriaxone. For patients that are hospitalized for greater than 2 days, these are considered hospital-acquired sepsis, and the recommendation is to initiate cefepime and vancomycin. In our neutropenic patients, the recommendation is to initiate cefepime. Vancomycin can be added if there is fever or other high-risk factors. In our oncology patients with sepsis, there is a separate order set / power plan that we utilize based on their risk stratification. And there's more and different regimens options in that power plan that is beyond the scope of this talk. In addition to the above regimens, additional regimens can be added based on other indications. So patients that have high risk of infection from central venous catheters, skin and soft tissue infection, resistant gram-positive, vancomycin is indicated for at least 48 hours. Metronidazole is also indicated if there is an intra-abdominal indication. Linezolid is an option added to the above regimens if there is concern for toxic shock syndrome, as well as if there is allergy to vancomycin. Meropenem is our carbapenem that we will recommend in place of cefepime if the patient has multi-drug resistant organism or cephalosporin allergy. Just want to quickly highlight antibiograms in the United States. At Boston Children's Hospital, we have a very robust antibiogram that we utilize, but I do want to let you guys know that there is a antibiogram that is specific for each state. This information is gathered from institutions within that state and is put out publicly by each local Department of Public Health. So anyone can go onto those websites and look at the local antibiogram. In the United States, when we are developing our antibiogram, we also utilize information that is put out by these local state Department of Public Health to tailor antibiotics based on resistance patterns around the area. So here are just 2 examples of susceptibility data from Massachusetts on the left and a New York City antibiogram on the right. So now I will be moving over to India, and I will be speaking on behalf of the pharmacist lead for Alice Nitha. This is an example of a sepsis screening tool in an Indian institution at India. This specific screening tool is specifically for neonate population. It is separated based on the age of a patient. And then moving further down in the decision tree, it is looking at if the patient has risk factors to initiate antibiotic versus observation, as well as includes some symptoms and components of sepsis that needs to be looked at. In the India Amrita Institute of Medical Sciences and Research Center, this is their recommendation for antimicrobial treatment if there are meningitis or sepsis in neutropenic patients. There's also recommendation below on patients, newborn patients with sepsis as well. In terms of antibiogram from India, this slide is a overview of gram-positive isolates and its susceptibility. Red indicates resistance and green represents susceptibility. In terms of gram-negative, this is the information. As you can see, majority of their gram-negatives are still fairly susceptible to the cephalosporins and some of the ciprofloxacin and levofloxacin as well. Thank you.
Thank you, Lisa, for that. So now we're actually going to look at Africa. Firstly, I'd like to acknowledge Dr. Tuti, who's a clinical microbiologist in Red Cross in Africa, for providing me the content and reflections about Africa. As we know, Africa's a vast country. It is certainly resource poor, so access to treatments can be difficult. We know that there is no one-size-fits-all. Well, there is a one-size-fits-all approach, whereas we've seen here that they can actually use like ceftriaxone, which is a very extensive, broad antimicrobial, can be used prophylactically for post-surgery. Point-of-care testing, which we see at all hospitals in Queensland and certainly imagine similar in US, is certainly not readily available, and that's making it harder to actually identify that they actually do have a risk of infections or serious sepsis. We know that that they have a higher risk of mortality in that part because, again, they may not be recognised that they actually do have sepsis. And we also know that local guidelines vary in each health district, as it depends on, you know, what's available at that time there. So now here she's we have the epidemiology of resistance in Africa. So here it's looking at a systematic review on what's been available. The data is only including about 40 to 50% of Africa compart. There was 144 articles looking at what the resistance. Again, it's out of date now, but it was from 1995 to 2015. It looked at 13-gram negatives and 5-gram positive bacteria across 37 different antimicrobials and found that the data could certainly be improved. There was significant differences in this methodology and how they interpreted that. But the main thing is what they identified, that there were very strange combinations used and results. And the level of resistance to common antimicrobials certainly was quite noteworthy. And that's something that we do need to think about, looking and thinking wisely about how we use our antimicrobials. So if we further here, moving on, we have an interactive dashboard here where we can look and choose an organism and an antibiotic, and you can hover over a country and tell us what the proportion of isolates tested that were resistant and the number of isolates tested, whereabouts, and where the information come from. So it's an illustrative purposes here. We've got a snapshot of the map and it's superimposed information on each country, and that's looking at Klebsiella and meropenem resistance. And you can see the value of this type of dashboard. So if we look here, we've got United States has 3% resistance. We've got Egypt having 72% resistance, and Kenya 23%, and South Africa 7%, and United Kingdom being just 1%. Now, if we look at the next option of the dashboard is looking at staphylococcal infections and looking at oxacillin. We don't use that here in Australia. That's similar to our flucloxacillin. But you can see that this has got certainly resistance here of Ghana of 19%. And you can see Nigeria's 63%, South Africa's 27%, so certainly quite concerning here. United States has 45%, so there is concern about using that particular one with the significant resistant patterns. With United Kingdom following on with 7%, so they're a bit better than that. So if sepsis is suspected, we need to think about trying to secure the access. We need to try and look at obtaining cultures and certainly start empiric antimicrobials within that first hour, looking at that sepsis, the surviving sepsis guidelines. Fluid resuscitation, maybe considering the balanced solution. Use of early inotropes if it's needed. We need to think about managing the organ dysfunction, whether they actually needed support or how we're actually going to do that, and do that early to help the patient survive this crisis. So if we now look at our take-home messages, we have sepsis. Certainly defining it can be difficult. Sepsis tools are available and certainly do make it easier, but we need to use those. There's certainly not a right or a wrong answer here. So we need to take into also account the family plays an important role and advocates for their child. So listen to their concerns and remember to ask the question, could it be sepsis? Everyone's in a team, so you only have to ask that question and question it, and you could be right in that component or help or even think outside that box. The Surviving Sepsis campaign, as I said, mentions that we need to use antimicrobials timely and certainly ideally within the first hour. Here we need to actually make sure we have the right antimicrobial, the right dose, the right frequency, and the right administration time, and to make sure that we're actually managing the pharmacokinetics and pharmacodynamics for the antimicrobial and addressing the pathogen. We also need to think about, do we need to have early inotropes or fluid resuscitation and address those? We do know, and as we can see, antimicrobial treatments around the world vary significantly. There are similarities, but we all do work differently. We need to look at those local guidelines, see what the resistant patterns are, and try and remember to use antimicrobials wisely. And for questions and contact details, we have myself here, I'm Michelle Creed, and we have Lisa Lee, who is from Boston Children's here. So thank you, Ali, over to you.
Thank you so much to all the presenters. That was fantastic. A really great multidisciplinary view of sepsis. So thank you all. I'd really like to open the floor now. If you can either add questions to the chat or raise your hands, that would be really great. And we welcome questions to the panel, please. We did have one question in the chat as well from Tony and Two. For children, can we use high-end antibiotics like ceftazidime and avibactam? Alice has also contributed to the answer of that, but would Michelle or Lisa like to do any further on that?
Do you want to start, Lisa?
Yeah, I can definitely start. We definitely have this antimicrobial, this extended spectrum cephalosporin at Boston Children's Hospital. It is not part of our empiric antibiotic recommendation. It really is, first, it is restricted at our institution, specifically from ID consult and approval, which means that infectious disease team needs to review the patient's history as well as their microbiology susceptibility to really make that recommendation. So we will never use it for empiric coverage unless the patient has a true indication for it, but it is definitely can be used for that specific bug.
I agree with Lisa. Certainly at our institution, and even throughout the state, we also do have it available, but we do not use it in our empiric guidelines. It's mainly predominantly and very much restricted and needing infectious diseases consultant involvement when we are using that antimicrobial.
Thank you very much, Michelle and Lisa. I wanted to ask, I mean, this is a pretty broad question, but, you know, we've seen through you exploring and kind of showcasing different regions in the world and their approach to antimicrobials. What do you really think we need to do in terms of improving antimicrobial treatments to the children who are in critical care? If either of you would like to answer that. We also have another question in the chat after.
Do you want me to do that one, Lisa? I'll start off. So, like, I certainly can see that what I see that we should be improving is certainly doing some research to actually understand how the pharmacokinetics of antimicrobials work in critically ill children. We know that they actually have altered pharmacokinetics. We do know that their volume distribution and clearance is altered, and we need to work out that we're actually giving adequate dose or optimized dosing for them. Ideally, if we can actually have timely therapeutic drug monitoring for every antimicrobial that we use, that's my pie in the pie dream, would be fantastic. Then we know that we're actually getting a targeted approach. But we'd like to have very timely response, so you can actually make those changes instantaneously. At the moment, it is delayed, and some drugs it can take up to 8 hours or even 24 hours or longer to actually get a result, to work out how we can optimize those treatments. And the other part of that is if we don't know what we're actually doing in our critically ill children, then the extension of that is we're not doing very well in our extracorporeal patients. And what does that actually make a difference? And how do we manage those, as we know they are the sickest children in our units?
Thank you, Michelle.
Yeah, I 100% agree with Michelle as well. I think therapeutic drug monitoring is definitely a field that we will hopefully in the future, or even in the near future, get some better data.
Thank you, Lisa. And then Alice has asked, how long should we use meropenem and colistin in neonates and infants with sepsis resistant to other therapies?
I think it really depends on where the sepsis is originating from.
Yeah.
Depending if it's a bloodstream infection, if there is urosepsis, pneumonia, I think that all changes the course of therapy.
Completely agree. You really need to target the source and the pathogen, and then work out how, and that really gives you an idea of how long in duration, depending on what we're actually doing. We don't use colistin at all at our institution, and meropenem is very restricted when we do use it, and when we do use it, we actually may even look at doing levels to actually try and improve and optimize that treatment. But again, it depends on what we're actually trying to do. If you're actually trying to get it into the CNS, then you might need to think about how you're actually infusing that. If you actually are wanting better perfusion, you might, or they have acute kidney injury, we might need to extend the infusions. So there's so many different ways on how we actually may treat, and duration is one part of that, but also how we actually give it is a different thing as well.
Thank you. Any further questions? Well, I'd really like to thank all the panelists for your presentations tonight. I found it really interesting myself, and I think it's been a great global representation and multidisciplinary representation. So I look forward to the next WFPICCS Allied Health Education session. And I'd really encourage you all to follow the activities that are going on as we progress towards the Congress, our first face-to-face Congress in Singapore, in Cancun next year in June. The abstracts are open and they close at the end of January, so please submit any of your research and abstracts. We're really, really looking forward to being able to catch up with the global critical care network from around the world. I think it's a wonderful opportunity. And I really encourage you to link up with others on social media. And I think this is such a great forum to share education, share our clinical guidelines and our expertise from around the world. So thank you very much.